Dr. Joseph Cachionne is interventional cardiologist in the Robert and Susan Tomish Department of Cardiovascular Medicine in the Arnold and Seidel Miller Family Heart and Vascular Institute. He's also the chairman of operations and strategy at Cleveland Clinic. What's important about Dr. Cachionne, and again, in the brochure you have here, is he has a very extensive clinical background. But I want to point out one of the great reasons that we began working with Dr. Cachionne is he also has a very important role and a mindset to help improve for the business side of healthcare as well. And it's very difficult to solve the business problems in healthcare without having a strong clinical background involved in that as well. So if you're really going to go back to that slide I showed before around the two individuals we're trying to improve the outcomes on, having the clinicians doing this with us is essential. So without further ado, I'll introduce Dr. Cachionne.
Thanks, Marcus. I hope I don't screw up the slides either. I said I have a big thumb. They said, well, you're an interventional cardiologist. That's a bad sign if you have a big thumb. So it's the right thumb. I have to use the left one. So anyway, I have to say that I'm pleased to be here and pleased to hear the activity about real-world evidence that Ann was spent time talking to Kurt from the Indiana Health Exchange, and I laud Indiana for that because it's something that I think most regions would really aspire to. And I know Wisconsin's had a lot of activity, and there are exchanges, but the Indiana Exchange is really well developed and very well positioned to help providers really drive change into healthcare that will be both meaningful from a clinical standpoint and from an economic standpoint. And I don't think you can divorce the two anymore. The fact is we can't afford to continue to pay $8,000 per capita for healthcare like we do in this country, and the rest of the world is less than $6,000. So we're going to have to. That is the elephant in the room always, is how do we pay for this? We have a great healthcare system, but we got to be able to afford it. So what we've endeavored to do is to start to transition and change the incentives and change the paradigm that more care is better. And that is a difficult thing to do because I've been in healthcare 22 years. It's very difficult for people of my vintage to change their thinking that more isn't better. And it's actually very difficult for the patients to think that more isn't better. I used to tell our board members, they always want, well, give me the most expensive. For my employees, it's different, but I want the CAT scan. For them, we just want very effective, efficient care. For me, I want everything. So we have to develop models that will do that. So what we did was we'll start to change, and what our approach has been is develop and to really leverage data that we have. We're very rich in clinical data at the Cleveland Clinic. And taking that information, merging it with claims data. We had a unique opportunity to partner with HealthCore and WellPoint and AstraZeneca to start to look at this and start to look at real-world evidence. And then to use that to help drive our care paths. And I'm going to go through an example of that, why that works and why it's different than what others are doing and why it's different than what needs to be done. So we also see, as opportunistically, we see this as an opportunity to drive volume, because those of you who are purchasing healthcare, you want to change that paradigm that more is better. You want to change that paradigm, and RAND has done a study showing that only two things will change the healthcare cost or bend the healthcare curve. That's putting providers at risk and making patients more responsible for their own healthcare costs. So, but we see this as a way to help drive patients to us by taking opportunities and taking risk and taking it off the employers and taking it off of the payers. We have used that, and we are participating with the government and the CMS bundling pilot. And our keys to success really are about standardizing the care, the ability to provide outcomes, continue to drive to superior outcomes, which we're noted for, and then to use the integrated data sets of both the claims and the clinical data to drive these improvements, and then to also try and drive more competitive pricing. So we always make the argument that Cleveland Clinic has about a 15% premium to the marketplace on aortic valve replacement. But when you look at that in a longitudinal fashion over a one-year period, that premium is now only 5%. And because of the improved care, the improved outcome, patients are doing better. And so when you look at that on a population basis, that premium is now 5%. Our outcomes are in the top 2% in the country for aortic valve replacement. So are you willing to pay a 5% premium or a 20% premium for the best outcome? Well, it's a lot more palatable to pay 5% than it is to 20%. And so increasingly, well-positioned and well-informed healthcare organizations will need to be able to show that value of what they do, not just in an isolated event that occurs at the hospital, but what is the value of that patient? And you heard about patient-reported outcomes, and what are the longitudinal costs, and not just about the event that occurred in the hospital. So we embarked on this. We have created work streams for this. It's around, and the one thing that strikes you as you start to peel this onion back, just how complicated our healthcare system is. I think Marcus alluded to that this is not easy stuff. It requires a lot of administrative changes. The health plans themselves have trouble processing just a episode claim. You then have to go out and take that process, that new process of care, and have to go out and they have to be able to turn that into a contract with an employer. And so there are logistics to that. And then you have to be able to define the episode and what's it anchored by. Patients don't really know that they live in an episode. This is just some arbitrary way that we define a patient or some illness. And so patients don't understand that. Patients don't understand that I might be at risk. They may show up at the emergency room across the street. So we have to, the systems are going to have to catch up. And the health plan people freely admit that their systems are behind on these issues. So we did the initial pilot in our employee health plan. We did it around orthopedic care, and we developed sort of the model of what we wanted this to look like. And I think orthopedic care lends itself very well. Joint replacement is an isolated event, starts at a defined period and goes forward, and there are opportunities that occur. So what we then did is we started developing episodes across many of our product lines, and that includes coronary bypass surgery, PCI, which is stenting, and then we have worked with Optum Insights, which is a company, a division of United Healthcare, which has developed bundling tools which sort of aggregates the claims and relates them to the initial diagnosis. We're now doing this in several different diagnoses, and we are collaborating with payers, and in particular, HealthCore, and the data we're going to show is the proof of concept of what we're doing with HealthCore and Anthem at this time. So what we set out to do is to help create a risk-adjusted episode so that if my patient, doctors are great at saying, oh, my patient's always sicker, and that's why I spent more money on them. That's our first excuse. That excuse went out the door back in the early 90s, and we created risk-adjusting models that were valid. But the way risk-adjusting models have been done traditionally have been through the use of claims data. And the fact is risk adjusting based on claims data is not valid, and it also doesn't sit well with providers because claims are a matter of history. They're not a prospective view of a patient. They're a matter of historical, it's a historical record. And just as Marcus identified, the claims data are notoriously inaccurate. So you missed 40% of diabetics. Boy, that's a big variable that is missing when you start to just use claims data. So what we did is we set out to match that with our robust clinical records, which most hospitals have these days in cardiovascular disease, is registry data. The reason why we chose registry data out of the gate, not raw data from the EMR, is that registry data has a risk-adjusting methodology that is nationally accepted already. So it sort of shortens that cycle time to start to look at risk-adjusting methodologies as it relates to a total episode of care. We then did a statistical analysis by combining these two data sets, and we used a bunch of different models to relate these variables and start to now produce a list of variables that can be provided to a clinician at the point of care that will tell them your patient is at risk for either an adverse outcome or a high cost of care over the next 6 months or a year. And so that list of variables then, so if somebody falls into that list where there are 10 variables that are all positive, that patient is going to be expensive. And so we then would enact care coordination. We will do things through the care path to help reduce that variability and help guard against that added resource use. Now, you can understand how that might work from a business standpoint as well for the Cleveland Clinic. If I'm able to contract for a fixed price and I'm able to reduce the utilization, boy, that money then is all profit to the Cleveland Clinic. Now, at the end of the day, what we're really looking to do is reduce the overall cost of care. And as we go at further risk and providers go at further risk, it's going to be a defined contribution rather than a defined benefit. So we're going to get a pot of money, and we're going to have to manage those patients within that pot of money. So this is the distribution of this is the proof of concept. And if you look here on the slide, this is the full episode price, and you can see that there's quite a bit of clustering in two areas, and then there are all those ones that are on the trail out. So that's the full episode price, and then the blue bars are the relevant post-acute or the relevant acute care. Meaning, if you have a stent put in today and you have your gallbladder taken out 3 months from now, that's not related to your stent. But if you come back in and have an echocardiogram and get readmitted for chest pain, that is related. So that's what the difference is here. And then lastly, you look at the relevant post-acute care totals, and you can see a spike very early. And what we're finding, and this is pretty common, is that most of the relevant post-acute care stuff, and this is diagnosis specific, really cluster in the beginning. And for orthopedics, for joint replacement, this is drastically different, by the way. 60% is related to the hospital event. 40% is related to the post-acute care. So you can see then we do these clusters, and you can see the class, and you can see now, and these are standardized prices so that we don't divulge our pricing information. But if you can see, there's clustering around 3 groups of patients, around $10,000. Around $16,000, and then the average, which is or the median price for the outliers, is around $35,000. So what we're now starting to understand is, can we contract with somebody for one of these episodes, and based on what variables? And so when you start to look at what variables will produce the things, and this is for angioplasty or stenting, you can start to see that there are variables that sort of shake out all the time, and so that we will use those factors to sort of change physician behavior. We will also use those factors to maybe add resources to a patient that falls into that higher risk group to try and manage them down into a lower risk group. So this is where we think this is going. We're excited about what our project is with Health Corps and the Anthem data. We are expanding this and building this model so that it will automatically refresh itself over time. We look for collaborations with health plans today, because the one thing for providers that don't have health plan data or have claims data, it puts us at a disadvantage. And in turn, the health plans don't have clinical data, it puts them at a disadvantage. So we think there is a natural partnership here. There was recently an editorial in JAMA by Don Berwick, who actually created the law, but helped create the law, that Medicare data is not always available to providers. And that law needs to change, because we really need to get better access to that Medicare data. Medicare data is available, but it's only available for certain uses. And so, and in the work that the health information exchanges are doing are going to be critical to being able to do these analytics that are retrospective, that can provide the foundation for sort of prospective management of patients, to put that real world evidence in the hands of providers at the time when they're actually caring for the patients and where patients are expending the resources. So our process has been to bundle development, to merge the data sets, to define the drivers, and then to engineer those care paths and re-engineer the care paths and reverse engineer them, so that if you have overutilization of something that is occurring in the post period, that overutilization is not generally attended to by our guidelines. They tell us what we should do. But if I order a test on somebody that doesn't need to be done every time they have a stent, the guidelines don't address that. What the guidelines address, what the real world evidence will help us address through the use of claims data is, hey, Dr. Cachionne, don't continue to order that echocardiogram. It's not necessary. It has not changed the outcomes, and it's added to the expense. So we think this is how this will all fit together. Again, I would echo what Mark says, is that this is complicated, but it is not something, it is something that we have to take a stepwise progression on and continue to modify what we're doing. Otherwise, we won't be able to get the same outcomes we're getting in this country at an affordable price. So thank you.
Terrific job, terrific job. Thank you, Dr. Cachionne.